Huck. Hi, my name is Julia Barron, and I'm a nursing student here at Bellarmine, and I'm going to be taking care of you today with your nurse. I'd like to go ahead and identify you by your name and date of birth. Alan Abdullahi, nice to meet you, 12/18/1948. Well, pleasure to meet you. I'm going to be taking care of you today, and I've already obtained your vital signs, and I'm going to be moving into doing a respiratory assessment. And this respiratory assessment, when I get my findings, I'll be talking to you about that so you know what's going on, and then I'll also let your nurse know of anything that's going on. I'm doing just a general overview of my patient, very similar to what we did for skin. So I'm looking at that general color, I'm looking at his face, I'm looking at his positioning. You're sitting upright. Is that more comfortable for you to breathe? And he tells me that if he lays down, it's really hard for him to catch his breath. That this has been going on for about 2 weeks at home. Okay. When I did his respiratory rate, it was 24, so it is tachypnic. And I would like to add to that, besides doing his 10 pulse, respiratory rate, and blood pressure, I also want to get a pulse oxygenation. So this is going to be important for my patient to see if he's having hypoxia, and that would be showing up. So he's on room air right now, and I'll just give that a minute to read. I'm looking at the general appearance again with your hands, your fingers. I'm looking to see if I see any clubbing. I don't. You don't have a smoking history. That's great. When I'm doing that general appearance, so he's 91% on room air, so he is having some problems with hypoxia. Go ahead and take some slow deep breaths while I finish assessing you, okay? I just want to get a general appearance also of the rest of your extremities to see how your circulation is going. Very good. And we're going to say that this patient has pneumonia. So I'm also looking at, besides your counting your respiratory rate, I'm going to see if the rhythm is regular. Irregular, it's regular. I also want to know if there's any kind of audible noise, and you have an occasional cough, and it's a deep cough after some shallow breathing, and you're bringing up some purulent sputum, and you've been doing that for about 2 weeks. You feel like you haven't been clearing it all out. It's just been hanging in there. I'm going to check to see if you're having any accessory muscles, and you're not. I'm going to go ahead and leave this down so we can finish assessing you. When I'm looking at his chest, I'm making sure that he's having equal expansion on each side. You can even put a hand on each side and look to see that it's equal on each side, and it's great to look at that posteriorly as well. Looking at his anterior posterior diameter and transverse diameter, so that anterior posterior should be 1, and then that transverse is 2, so it's a 2-to-1 ratio, with that transverse being wider than the anterior posterior. And I'm also looking at the costal angle right here, and hopefully that's going to be about 90 degrees, and you can think of it like a piece of paper. Looking at my landmarks, which I'll go ahead and start to move into inspection, and then you're going to move into palpation. But when I'm doing my landmarks, I'm going to see that the sternal notch is right here, suprasternal notch, and then the manubrium, and I can feel that angle of Louis, that little bump, and that's going to be my second rib. And then, of course, in order to find my costal angle, I would be looking for my xiphoid process. And then posteriorly, I'll show you when I see the T7, T1. So I'd be looking for that just at that posterior neck where that bump is. Continuing to look at your nail beds. Again, pink, cap refill less than 2 seconds, and you're warm to touch. You're relaxed. I don't see any pursed-left breathing as long as you're sitting upright. You're not tense. Your facial expression is calm. Your level of consciousness, you're alert. I ask you if you know where you are, what date it is, who I am, why I'm here, to see if you even know the situation. I'm not seeing extensive drowsiness or irritability or restlessness. So look at the posterior chest for palpation. So when I'm looking for confirming that symmetric expansion, I'll go ahead, if you look through here, turn him from the side, and I can see that his chest is expanding equally on both sides, and I would be placing my hands posteriorly on him. So if you could go ahead and just turn a little bit to your side. Thank you. Placing one hand on one side, one hand on the other side. Have him take deep breaths, and make sure your hands are expanding on both sides adequately. If he had maybe a paralyzed diaphragm or an area of consolidation or chest injury on one side, that may not be a symmetrical expansion. I can also feel at that time too for tactile fremitus. Typically you're going to find that posteriorly, but areas over consolidation, I'm going to feel that vibration more. You also may feel check to see if there are any masses or any kind of crepitus. That would be almost feeling like bubble wrap underneath their skin. Sometimes people that have a chest tube might develop an air leak and get crepitus underneath their skin. So we can move over to auscultation. Typically we stand on the left side for auscultation. So we'll be doing that. And I'll be using the diaphragm part of my stethoscope, and I would like to proceed in an orderly manner. That way when I'm moving to my documentation, I can remember what areas I'm hearing my lung sounds over. So feeling for that suprasternal notch, finding the angle of Louis, and feeling that second rib then. I can go ahead and I usually go left to right. That way I can remember what I've heard. One inhalation, exhalation. So I'm upper lobe now. Typically about the nipple is going to be your fourth or fifth intercostal space. And by listening there, I would find that I'm going to just the base of the upper lobe going to lower lobe. And then going quite laterally to get that mid lobe. Again, quite laterally. And get the lower lobe. Okay, now I'm going to go ahead and listen posteriorly. And I'm going to have you tilt one side and then tilt to the other. That way I can listen. So I feel for that C7, T1. So I'm listening to mostly upper lobe right now. Just for the size of this individual, I'm going to go down the left side and then I'll go down the right side. And at probably about thoracic 10 or 9. You can feel the scapula and just listen distally to that. Going to walk around to the other side. Thank you so much. And finish listening on this side. Upper lobe. Can feel the scapula. I'm going right around it to the lower lobe. Good. If your patient talks while you're doing the assessment, you may hear that his, since he has pneumonia, areas of consolidation, his vocalizing might be clearer. I might hear more vibration, clarity of sound over those areas, and I would be hearing crackles in the lower lobes. And it would be on that light inspiratory phase, so breathing in and if you popping open the alveoli and you'd hear crackles. He also reported that he had that purulent sputum. I saw the tachypnea with seeing his respiratory rate, the shallow breaths, and then that deep breath with a cough. So that's a good description of what is happening. So if I heard any absent breath sounds or if they were decreased to an area, versus being able to hear them all the way down with that atelectasis. Sometimes they might be decreased if an area is consolidation and you're not getting air in there. And then I did hear the crackles. I did not hear wheeze, which is more of a musical sound, and it may be a sonorous sound, kind of like snoring. And I didn't hear any squeaking. That'd be a pleural friction rub. All right, I think we're all done. If you have any questions, please let me know. Otherwise, I'll let your nurse know the findings that I had when I did your assessment. And I'm just making sure his bed is in a low lock position, call light is in place, and his personal belongings are within reach. Thank you so much.